Good morning, Feral and Ambulance Corps, and welcome back to the next episode, episode 12. This time, based on recent events in the news, such as the shooting at the Chiefs Parade, I thought we should talk about a topic that's becoming more and more reality is care under threat, and how you might handle situations where there's some kind of active threat still going on. So without further ado, let's get into it. Please take a moment to review the usual disclaimer. All right, so when we talk about care under threat, what are we talking about? So we're going to answer these 4 questions, hopefully at the end of this presentation. 1, what is TECC, which stands for Tactical Emergency Casualty Care? What are the phases of care outlined in TECC? How do I apply the XABCs and March algorithm? And then what is the lethal diamond of trauma? So first of all, what is TECC? So TECC, like I mentioned, stands for Tactical Emergency Casualty Care. It is a set of clinical guidelines that was derived by the CTECC committee. And TECC was born as an offshoot of the military TCCC or TCCC. I know it's a lot of C's. But the issue with just directly applying the military tactical combat casualty care to civilians is that the military population is different from the civilian population, and in a civilian EMS, we take care of civilian population. So as you can see by this comparison, right, in the military, they're taking care of mostly young, military-aged, healthy, predominantly males. It's predominantly a population that are combatants, and they're treating other combatants in a combat environment, and it's got a heavy emphasis on wounds due to bullets and bombs. Whereas TECC, which is an offshoot, like I said, designed for the civilian population, takes into account that the civilian population may not be healthy. They have chronic medical problems. There's men and women involved. There's chronic medications involved, like blood thinners, which dramatically affect trauma, right? And we also have to consider pediatrics, geriatrics, all different patient population types. And also, it's not just about bullets and bombs. There are other threats in the civilian world, such as fires, hazmat, biological. You can use this for any population. Okay, tactical emergency combat casualty care divides care into phases. So we're going to review what those phases are right now. Here's the primary phases. 1, direct threat care, sometimes also called the hot zone. Indirect threat care, also called the warm zone. And evacuation care, also known as the cold zone. And you can see these depicted graphically here in this document from the Hartford Consensus, which was put out by the American College of Surgeons. And the goal of these zones is to get care closer to the point of wounding and save more lives. Now, you can see the basic goals in each zone in the graphic. So in the direct threat zone, we're primarily focused on threat suppression and a little bit more. I'll talk about that in a second. In the warm zone, we're focused on hemorrhage control, extrication. We'll talk a little bit more about that. And then in the cold zone, it's going to come back to look more like your traditional EMS. So let's talk about these in more depth and more detail and really flesh out what kind of care you would perform if you ever found yourself in one of these situations. So in the direct care phase, the main priorities are 1, mitigate the threat, aka stop the wounding, stop the killing from whatever it is, be it a shooter or a hazardous material or whatever that threat is, burning building, etc. Extricate and evacuate and control life-threatening hemorrhage. That's it. That's it. Okay. Now, as for mitigating the threat, some of you might be thinking, oh, this isn't my purview. This is for the SWAT medics and law enforcement who are going in. This is for firefighters who are stopping the burning. This is for the hazmat techs who are doing the decontamination of hazardous materials. And most of the time, you're going to be right. As BLS EMS providers, most of the time, you're not going to be operating in the direct threat zone. However, I think it's important that you understand what goes on there to know, 1, what, if any, medicine is provided there, and 2, situations evolve. What was not believed to be a direct threat zone may become a direct threat zone, and you may unintentionally find yourself in one of these zones if a scene changes on you. So I think it's important for you to know and understand it, even with the understanding that most of the time this is not going to be your, assigned role, but it may be a role that you end up with because you found yourself in the situation and now you need to deal with it. So, again, this direct threat zone is predominantly for the law enforcement, the SWAT medics, the people who are mitigating the threat, right? And that could be, firefighters putting out the fire, hazmat, etc. But understand that you should understand what they're doing and understand what to do if a situation changes and now a threat has become where you are and you're now in a direct threat zone unintentionally. So we talked on the previous slide about mitigating the damage or mitigating the dying. That's what our colleagues are doing for the most part. What about extrication and evacuation? This is where drags and carries come in. And you guys have probably had this ad nauseum in your EMT class. I'm not going to review it in detail here. I actually think it's best for in-person session if you want to review this further. But this is what we are talking about when we say extricate and evacuate. In general, we're prioritizing speed over C-spine in these situations because there's an active threat and we need to just get the person out of there, okay? That's not to say C-spine isn't important, and if you strongly suspect it, you could try to, move the patient keeping in line. But for the most part, under these scenarios, we're making a conscious decision that the risks of staying in place outweigh the benefits, and we need to get them out of there, okay? And then the last part of direct threat care is to control life-threatening hemorrhage with tourniquets. That's pretty much it, okay? So you're going to throw tourniquets on, and these are going to be hasty tourniquets. So what is a hasty tourniquet? A hasty tourniquet is a tourniquet applied over clothes, and it's applied high and tight. So if I'm doing it on the arm, here, I'll just try to get my arm in the little view there. I'm going to put a hasty tourniquet up here, whereas a more targeted tourniquet, I might put lower down or just 2 to 3 inches above the point of wounding, like down here. But in the heat of battle, in the heat of whatever's going on there, the initial tourniquet is going to be a hasty tourniquet, high and tight, and it's going to be over clothes. Okay, and it's going to be as high as you can go, so almost up in the armpit, just below that. Okay, same thing in the groin. Okay, you're going to put it as high up as it can go for life-threatening extremity external hemorrhage when you're doing this in the direct threat zone. So let's just summarize direct threat care. So you're going to protect yourself, protect the casualty. You're going to use drags and carries to get the patient out and stop any life-threatening hemorrhage with a tourniquet. Remember, this is, again, often a law enforcement, fire, or hazmat or other branch role, but if you find yourself in this situation, you now have at least a quick idea of what to do here, okay? All right, so let's talk about phase 2 of care in TECC. That's the indirect threat care phase, okay? This is sometimes called the warm zone, okay? Now in this phase, we're going to be focused on primary survey and life-saving interventions, rapid evacuation, plus or minus the setup of a casualty collection point if that's not going to be possible, and then you're going to start damage control resuscitation. Now, depending on the situation, maybe you might find yourself in a warm zone, maybe. Still probably in the cold zone, but I think you should know and understand this content so that way you are prepared if you're asked to go into a warm zone, what that is, okay? And what the warm zone is an area that's away from immediate danger, but is not considered completely secure, okay? So that might be an area which is protected by security, but we haven't, completely secured the area, or we believe we've neutralized the threat, but we don't know 100% for sure. It's kind of that in-between zone. It's not in the area of active combat or active operations, but it's close to it. It's closer than in the cold zone. So we have to focus our medical care to the highest priority items, and these are the highest priority items there. Now, often in BLS, we don't really talk about damage control resuscitation. I think it's worth at least talking a little bit about with you guys. I want you guys to understand this and understand what someone who's doing ALS might be thinking of. But the basic concept of damage control resuscitation is you're doing the minimum high priority stuff to preserve life. Okay, that's the basic concept of it. You're not doing the definitive management of anything. You're just trying to buy time and get to the higher level of care. We'll talk a little bit more in detail about it later. Okay. First, let's talk about how you're going to adjust your primary survey and life-saving interventions. And this, I think, is really important for you because this is applicable not only in indirect threat care, but I think really in any seriously injured trauma patient you have in any situation, whether it's a TECC situation or not. So this is good for you to know no matter what. So what am I talking about when I talk about focused primary survey in the context of TECC, or for that matter, any traumatically injured patient? This really applies, I think. So there are different mnemonics you can use. I learned the XABCDE, so I tend to prefer that one. Other people have used March. Either way, whatever one you like more, they really get you to the same place. So if we look at the XABC's mnemonic, X is for exsanguinating hemorrhage. Some people call it extreme hemorrhage. But the first priority you're doing is controlling major bleeding immediately, okay? If we look at March, M stands for massive hemorrhage. Look, they're exactly the same, right? Massive hemorrhage comes first. Then airway, breathing. In March, to make an R, they say respirations, but more or less you're looking at breathing, right? Circulation. So they're really exactly the same up to that point, okay? D stands for deformity in XABCs, whereas H stands for head injury and hypothermia in March. Head injury and hypothermia is going to be covered in the everything else part of XABCDEs. I do think that head injury you should really consider ahead of the deformities, but it's just the way the letters work. So anyway, head injury and hypothermia are really important. And then E for exposure, exposing the patient to find all the wounds. Environmental, taking care of the hypothermia, and everything else. And they both end with everything else, okay? So pick which one you can remember more easily and use it. Honestly, this will benefit you in any trauma patient you encounter, not just in tactical emergency casualty care situations. So this is good for you to know no matter what, okay? Now, just to explain why we're doing this, okay, I think it's important for you to recognize that if we look at the causes of death, okay, death from arterial bleeding is in 2 to 4 minutes. This is why TECC and TCCC have developed, because people are bleeding to death before anyone gets to them. That's why there are these tactical emergency casualty care guidelines developed to try to get care closer to the point of wounding, because the longer we wait, the more people are dying, okay? Now, this doesn't mean take unnecessary risks to yourself, but just understand the concept of why we're doing this is because you die of bleeding the fastest, and that's why it's now put first in those primary survey algorithms. And so the other thing to consider with this is I want you to notice this, because holes in the chest, like sucking chest wounds and tension with thorax, they're very visually impressive. Paramedics like to, oh, we got a needle decompress, There's no point in needle decompressing anybody if they have uncontrolled arterial bleeding, because they're going to die from that first. Tension with thorax takes like 10 minutes or so to kill you. So there's no point in progressing to tension with thorax if you haven't stopped the bleeding first. So that's where this comes from, okay? So it's really important. It's time sensitive. It's where EMS can really make a difference because you're getting there first, okay? It also means don't dilly-dally on scene with major trauma patients, because you're ticking their time away and they need definitive management eventually. So just get these patients to the ER, okay? That's the really most important thing, preferably a trauma center, all right? Now, I mentioned the other part of that was the primary survey and life-saving interventions. What are the life-saving interventions that you can do at the BLS level? One is tourniquets. 2 is airway adjuncts. That includes BLS airway adjuncts. That includes warming the patient up, which is why the blankets are there. And don't forget this. Hypothermia kills trauma patients. Okay? Really important. Keep them warm. You need to expose them initially, find all the wounds. Then you need to keep them warm once you've controlled the bleeding. And then lastly, you can put on a chest seal, like these hyphen chest seals. Just a word on chest seals. These are non-occlusive chest seals because they have a vent. So air can go out, but not in. That's really important because if you put a completely occlusive chest seal, you need to monitor for reaccumulation of air and reoccurrence of tension with thorax if that air can't get out. So these are the life-saving interventions that you can perform at the BLS level. All right, so let's talk a little bit about the lethal diamond of trauma. And I mentioned you should understand something about damage control resuscitation earlier. This is the fundamental basis for that. So in trauma, it's been classically taught as a triad of hypothermia, coagulopathy, and metabolic acidosis that leads to death. Now, more recently, I think people are recognizing that hypocalcemia is the fourth parameter to make this a diamond or tetrahedron. That's really important that you need to correct if you're going to stop someone from dying from trauma. And this paradigm, I've showed here on each side what BLS and ALS can contribute to the situation. And by far and away, the most important thing you can do as BLS is control the bleeding. You can also use BLS airway adjuncts. You can also put that non-occlusive chest seal that, like the example is the hyphen one. Again, I don't have a particular brand preference, but that's a common one that's out there. You can expose, find all the injuries, you can get the patient out, and you can environmentally control the patient with blankets, by cranking the heat in the ambulance. Okay, there's a lot you can do at the BLS level, and then the ALS resuscitation part comes in with IV and IO access, blood products, TXA, etc., what I've listed here, okay? But I want to point this out to you because you can really make a difference in trauma with these BLS interventions, because these are going to help stop the factors that are in this lethal diamond of trauma. The longer bleeding goes on, the more, the more acidemic, the more coagulopathic, the more all these things get worse and worse and worse. The hypothermia worsens it all, okay? The sooner you can do these things, the sooner you could start to break this cycle until you have ALS who can get you blood and calcium and TXA and other things. And honestly, it's not worth waiting for ALS most of the time. You're better off running to the hospital in most of these situations, and getting to a trauma center faster is going to be better than waiting for these ALS interventions. I want to make that clear. You should not wait for this. If it happens to be there, it's there. But in general, trauma needs to go to the ER fast. Okay? This is just a reminder of that. In the warm zone, remember, you could get caught up like, oh, I got to do march, got to do all these things. But you don't want to really stay and play in the warm zone. Remember, you either need to set up like a semi-secure casualty correction point if you can evacuate, or you need to evacuate as soon as you can. Don't stay and play there. This is a load and go situation, not a stay and play situation. So get out of the warm zone as soon as you can, even if you haven't finished all the other stuff. Okay, you just got to get out of there. Okay. So let's just summarize indirect threat care. So remember, this occurs when the threat either has been neutralized but the scene not secured. It occurs when there's really, you're in an area, there's no obvious threat, but it's not considered 100% safe yet. A casualty collection point, I threw that term around. I should probably mention what it is. It's a pre-designated area for stabilization prior to evacuation. So sometimes you may need to set up one of these. If you can't evacuate everyone immediately, that you need to have a pre-designated stabilization area until evacuation becomes an option. You're going to rely on that XABCDs and MARCH algorithm for care in the indirect threat care setting. And this is where we start our damage control resuscitation. Keep in mind that lethal diamond, especially the hypothermia, that's the easiest one to forget, and you can affect that as BLS providers. And remember, don't delay evacuation. Don't get caught up in staying in play and doing all these things. When you have a way out, get out. And then let's talk about the last phase of TECC in the phases of care, and that's evacuation care. And in this phase, you're primarily going to be triaging for priority and destination. Notice that's the first time I mentioned the word triage, right? Is we're now at a place where we can actually kind of triage priority and destination. And pretty much this is back to conventional EMS at this point for the most part. And the emphasis is again on damage control, resuscitation, doing those high yield interventions. Okay. So let's summarize what we learned today. We learned that tactical emergency casualty care provides a set of guidelines that are adapted from military lessons in tactical combat casualty care to the civilian world to give us an approach to taking care of patients under threat. TCC is an all hazards approach, right? It can be any threat. And that might be a burning building in a fire, it might be hazmat. It includes bullets and bombs, but it's not exclusive to bullets and bombs. And then there are three main phases of care in TECC: direct threat care, where we're going to focus on threat mitigation, extrication, and tourniquets; indirect threat care, which is going to be guided by the XABCs and MARCH; and then evacuation care, which is going to focus on triage and the conventional EMS protocols. And that's triage for priority and destination. So hopefully you learned something through this. If you're interested, there's always more to learn about this. That's what I've got for you guys this time. I do want to give special thanks to E. Reed Smith, who taught me a lot of this content and also was kind enough to share his slides with me and help me spread this knowledge to you guys. So with that, thank you guys. Stay safe out there and see you on the next one.